Hi, my name is Catherine Salisbury. I'm a third-year internal medicine resident at Beaumont Hospital, Royal Oak. The case I'm going to present today is called I Drank Well Water in Portugal and Look What It Did to My Heart. So, brief introduction. Campylobacter jejuni infections most often present as acute infectious diarrhea. The sequelae following infection are well described and include reactive arthritis and Guillain-Barré, as well as many more. Here we report a case of a patient who acquired C. jejuni infection complicated by acute myocarditis. So our case, a 40-year-old male patient presented to our facility with several days of profuse watery stools without blood. He reported fevers, chills, rigors, and drenching sweats. He developed crushing chest pain and was referred to our emergency room by urgent care. His history was remarkable for recent travel to Portugal, where he admitted to drinking well water. He was noted to be febrile with a temperature of 102.7 degrees Fahrenheit. His white blood cell count and renal function were within normal limits. His EKG showed J-point elevation, and his troponins were elevated as well. So I've included this EKG from when he first presented to the emergency department, and you can see early repolarization evidenced as J-point elevation diffusely here in all of the leads. And his troponins were elevated as well. This is reported as nanograms per milliliter. At the day of admission, there were 7.24, and then came down the second day to 5.10, and the third day 3.13. So as far as workup and treatment for this patient, a cardiac catheterization was completed and was normal except for an ejection fraction of 50% with some apical hypokinesis. Stool cultures grew C. jejuni, and he received 7 days of azithromycin with resolution of his gastrointestinal symptoms, fever and chest pain. He was then discharged home and was doing well in follow-up with no evidence of additional sequelae. And he has continued to follow up with cardiology and has had complete resolution of his myocarditis, and his EF is now back to normal. So I just did a quick table on Campylobacter jejuni infection. We typically think of this as GI manifestations and symptoms, but as I kind of spoke about earlier, and as this case illustrates, there are a lot of non-GI symptoms that are associated with Campylobacter, and so it's just important to kind of keep ourselves aware of these. So the GI symptoms, which we're aware, are abdominal pain, colitis, bloody diarrhea, but it can also present as secretory watery diarrhea. And then some of the non-GI symptoms that in the literature are reactive arthritis, post-infection, there's Guillain-Barré, skin manifestations, pancreatitis, bacteremia, meningitis, and now myocarditis. So the conclusions and takeaway here for our case is that our patient's traveler's diarrhea led us to consider an infectious etiology of his myocarditis. Stool studies were in fact positive for Campylobacter jejuni, and myocarditis associated with this organism are somewhat rare, although there are several case reports in the literature. Campylobacter is a very common cause of gastroenteritis around the world and increasing in the United States, with an estimated 44,000 laboratory confirmed and 1.3 million total illnesses yearly here in the United States. And although myocarditis due to this pathogen appears uncommon, it would appear prudent for clinicians to consider myocarditis in patients who present with diarrheal illness or recent diarrheal illness and any cardiac findings. It's unclear whether actually treating these patients early with antibiotics would prevent myocarditis, and I think more data and studies need to be performed, but it's something to definitely think about and keep in the back of our minds. And then I just have my references listed here. Thank you so much for your time.